It's the right dose for a patient rather than the highest dose. So there are many patients who, once you start T-DXd, as long as you use a 3-drug antiemetic regimen, and then you warn them about diarrhea, they can use loperamide to manage diarrhea. They don't have any problem. They can continue with the 5.4 milligram dose every 3 weeks of T-DXd. But then there are some patients who have a difficult time with T-DXd in the first cycle, the second cycle. These side effects usually come on early. And so in that circumstance, you can up the supportive therapy, or you can even consider a dose reduction. So I often say it's the right dose for a patient rather than the highest dose. We just have to find what's the best dose for an individual patient.
Yeah, and I find that there's significant patient variability in terms of tolerability and who experiences the nausea and fatigue to what extent. I have patients who I think are older and frail and do extremely well on T-DXd with appropriate prophylaxis. And then, young fit patients who have a very hard time with the nausea and fatigue sometimes, as well as diarrhea. So I think it is about, appropriately starting that cycle 1, but also managing actively with subsequent cycles. We talked about you feeling that nausea is sort of a major side effect to actively manage in this drug. Let's get to more specifics. How do you manage nausea? What is that 3-drug regimen you're using?
No, absolutely. So in general, I start with 3 medications to prevent nausea. So that's primary prophylaxis. So one would be a 5-HT3 antagonist like palonosetron. The second one would be an NK1 antagonist, something like imand or fosphepitant. And the third would be dexamethasone. So that's the triplet regimen that I use initially to prevent nausea, vomiting. And if a patient is doing very well, then you can peel off, like remove the decadron.
Sure.
There are some patients who will have breakthrough nausea despite this. And in that setting, olanzapine seems to be a pretty good medication. Chlorperazine can be used, but olanzapine appears to work very well for nausea with all these ADCs, not just T-DXd, but other ADCs as well. So that's more of a breakthrough medication that can be used in this setting.
That's great. Yeah, that's certainly the approach I take as well. And olanzapine seems to help for a lot of patients. Occasionally, if someone has anticipatory nausea, do you use Ativan?
Absolutely. For anticipatory nausea or anxiety, Ativan, lorazepam works very well.
Great. Fatigue is something that was shown in the study to be, more profound with patients on T-DXd plus P compared to THP. Are there any strategies to manage that?
I think looking at the labs, some patients might have anemia, so that's something that's fixable.
Major.
Looking at the thyroid levels, patient could have hypothyroidism, not necessarily related to the drug per se, but in general. So once you've treated the reversible causes of fatigue, things to consider would be a dose reduction. And again, fatigue could be related to the dose. So if you decrease from 5.4 to 1 dose level lower, that could help with fatigue.
This is truly an area that I think we need to help patients with better. I think what we've got out there, some data for exercise, and then really much less sort of a quality of data in terms of pharmacologics that might assist patients, but certainly an unmet need too.